All right. Hi, my name is Akika Fukuya. I'm a graduate medical student at St. George's, and I'll be talking about chronic pain in older adults today. And I'll be particularly focusing around pain in people with dementia, and also I'll touch on pain assessment in this population as well. Okay, so just to start off with, I'll briefly introduce the types of pain. So there are different ways of categorizing pain, but pain can be categorized by acuity. So, for example, acute pain. This is a short-term pain, like the pain we experience from sprained ankle, and um, also persistent or chronic pain. This is the type of pain, for example, back pain or arthritis. Um, People tend to suffer from pain for a prolonged period of time if they have chronic pain. And recurrent or intermittent pain, so this describes the pain that comes and goes like a toothache. So this presentation, I'll focus mainly on the chronic pain. So this is clinically defined as pain that lasts for longer than 3 months or more than normal healing time. So there's a little bit of a lag. Can you hear me okay?
Yes, I can.
Yeah.
Okay, good. All right. Okay, so just to touch on the burden of chronic pain. So chronic pain it's an important public health issue because it can have a large impact on an individual level and also on societal level. And it's estimated that about 1 in 5 people globally live with chronic pain. And the economic impact of this is that in the UK, it indirectly costs the economy around 5 to 10 billion pounds for pain-related absenteeism, so people missing work, or poor productivity, so not being able to perform because of the pain. And on an individual level, it can lead to suffering, social isolation, and disability, which leads to reduced social functioning and quality of life as well. And on a system level, these pain-related complications lead to greater costs and demand. So, for example, painful conditions, for example, like arthritis or back pain, account for 1/3 of all claims for disability benefits in the UK. So it has a cost impact as well. In terms of what's changing at the moment, the WHO's new ICD-11 will be the first issue of ICD, the International Classification of Disease, to include chronic pain as the single disease entity. So this is a big step forward in improving chronic pain assessment and management, since ICD is used by governments when planning what services to fund, and clinicians refer to ICD classification not only for health insurance purposes around the world, but also when diagnosing and treating patients. So this improves awareness of chronic pain as a disease amongst healthcare professionals as well. And it also advances pain research and drug development. So in terms of chronic pain in older population, it's widely acknowledged that prevalence of pain is higher in the population over the age of 60. It's estimated that around 39% of those over 60 living in the community live with chronic pain, which is much higher than the rest of the adult population, where the prevalence is around 19%. But this is likely to be an underestimate, and because older adults are susceptible to being socially isolated and also susceptible to developing mental and physical disabilities as well, it's especially important to pick up and manage pain in this population early on. So chronic pain is the main reason older people visit hospitals and their GPs. The most frequent reason being chronic lower back pain, neck pain, and also chronic pain in the hip and knee, as you can see in this diagram. But chronic pain is a bit more complicated than site-specific pain that can be treated by just treating the location of the pain. So, for example, knee joint replacement for knee pain, because chronic pain affects multiple locations around the body over a prolonged period of time. So it's very difficult to treat, and it has an impact on multiple systems. So What's quite interesting is that the current literature also tells us that suffering from chronic pain itself might be a risk factor for developing cognitive impairment later in life. But likewise, cognitive impairment might also lead to impaired perception and processing of pain, leading to hypersensitivity to pain or lower tolerance to pain. So the relationship between chronic pain and cognitive decline is bidirectional. And particularly in those with cognitive impairment or dementia, a pain can present with behavioral changes. And that's quite problematic because it can be the only way that people with dementia or cognitive decline can express pain at times. So it's easily missed and often dismissed as a difficult behavior rather than being acknowledged as a separate disease going on alongside dementia. So then this delays assessment and management of chronic pain, and then it creates a vicious cycle of worsening pain and then worsening cognition. So to break this cycle, assessment of pain and having a low threshold for treating the pain in older population is very important. So just to mention a few sort of symptoms that's associated with dementia, so dementia is an umbrella term, so it can present in so many different ways, with the key features being these listed here. So memory impairment, impaired orientations, and executive function can be affected as well, so judgment and organization, and it limits activities of daily living. But the main hurdle for pain assessment in dementia is that as cognition deteriorates, the ability to communicate pain deteriorates as well. So it makes it difficult for healthcare professionals to pick up pain in this population. So how do we assess pain? So self-assessment scales are considered gold standard for assessing assessing pain. So especially in medical school, I'm sure the other two medical students here can relate as well, but we sort of memorize that line of where would you say your pain is on a scale of 1 to 10, 1 being very mild and 10 being an excruciating pain or worst pain ever. This is kind of the line that we learn for OSCEs, and I kind of just having finished OSCEs, that's kind of in my mind as well, but we don't really learn about how to assess pain when patients can't communicate the level of pain or experience of pain. So that becomes problematic when the patient has dementia, and it reduces the reliability of this method. And another method is FACE's pain rating scale. So originally it was created for children, and this can facilitate communication and assessment of pain as well. So there are many assessment tools available now, but the main consensus is that these are all useful when used in combination with each other to minimize limitations of each of the tools. So NICE guideline says that pain assessment in patients with cognitive decline should be done using structured observational pain assessment tool alongside self-reported pain and standard clinical assessment. And on the right, this is a diagram from a paper in the Lancet, also suggesting that we should assess pain at different time points, preferably before and after pain management, and then do an observational assessment, which should be interpreted together with the patient's emotional status, self-reported pain history, and also functional status as well. So just to give you an example of a pain assessment tool specifically for people with dementia, PAIN-AD is a pain assessment in advanced dementia scale. So this is a behavioral observational scale for assessing pain in people living with dementia who are not able to self-report. So this tool has 5 domains, which are, for example, one is breathing independently of vocalization. So this includes things like, is the patient, is there labored breathing in this patient? Is the breathing noisy? And the second domain is negative vocalization. So for example, is there moaning or groaning? And the third domain is facial expression. So looking at the patient's facial expression, is the patient looking frightened or is there grimacing? And the fourth domain is body language. Does the patient have tense or rigid body language? And fifth is consolability. So, for example, is the patient distracted or reassured by voice or touch, or are they just non-consolable? So this is just to show that there are tools that can be useful for healthcare professionals and also for family members and carers as well. So that they can detect pain at at an early stage when healthcare professionals might not be available. For example, while waiting in the waiting room of a hospital emergency department. So this is sort of my reflection after having written this essay. I had my geriatrics placement and I came across a few patients that were sort of in pain on the ward, and all of them presented like very differently. And I think it reinforces the importance of sort of being able to accommodate for each patient and for future doctors to be able to be aware of additional tools to use for people presenting with both pain and cognitive decline. So yeah, thank you very much for listening. I'm happy to take any questions if there are any.